Hi everyone, we're back for section 4 and we're talking about infestations of the skin. The first thing we're going to talk about is pediculosis, which is lice, and it can infect the scalp, the body, or the pubic area. Infestation can occur with nits or the lice. The nits are the eggs, the lice is the bug. Lice can lay between 6 and 10 eggs a day, and nits can incubate for 1 week and then hatch and begin laying eggs as early as 2 weeks. Head lice can live approximately 30 days on a host and lay up to 100 nits. Spread of lice can be as a direct or indirect contact and often happens by sharing hairbrushes, caps, clothing, or living in close living quarters or sexual activity for pubic lice. It is not considered a health hazard as it does not spread disease. Pediculosis capitis is very common in children. It's head lice, and all socioeconomic groups are affected, but lice are most common in school-age Caucasian females, with the peak season being from August to November. Lice is uncommon in African American children. And in my unexpert opinion, as being a school nurse in the past, a volunteer school nurse, it has to do with the texture of the hair. African American hair is very coarse, and Caucasian hair is most times smoother and easier for the nits to attach to. There is a condition called pediculosis corporis, which is uncommon in children, and this is where the louse isn't seen on the body but attaches to clothing and intermittently pierces the skin, and it is a louse that can carry human disease, but it is not associated in childhood. Pubic lice can be found in the scalp, eyebrows, eyelashes, and of course the pubic area. In your history, you want to note, has there been any infestations? Has there been concerns for dandruff-like substances in the hair? Is the scalp itchy? Is there any issues with a crawling sensation? On physical exam, you may note bugs in the hair of the lice. Nits are small white oval cases that attach to the hair. They typically attach close to the scalp, so the further away they are down the hair shaft from the scalp indicates the length of time that the lice have been there. As the hair grows, the nits will move with that. Common sites for lice include the back of the head, the nape of the neck, and behind the ears. Eyelashes can be involved. If there's concerns for body lice, you can have excoriated macule and papules, which may develop secondary bacterial infections due to itching. You may also find these along the belt line, the collar, in the underwear area, and there also may be associated lymphadenopathy. For pubic lice, you may notice excoriation and small bluish macules and papules. As we said, the eyelashes can be included, as well as the thighs, the trunks, axilla, and beard. Diagnostic studies would include tests for other STIs if pubic lice is found. Differential diagnoses include scabies, dermatitis, herpetiformis, and necrotic excoriation. Management includes making the correct diagnosis. Treatment is important when there is live lice and viable nits present, because empty non-viable nits or an empty sac can be present on the hair for several months. There are several options for treatment. Lice are known to develop a resistance to the pharmacological treatments that are available, as children have been treated multiple times. So treatment failure is common, and this may be as a result of poor technique or actual medication resistance. There are alternative treatments that are there, over-the-counter medications and prescription medicines, and even some dangerous substitutes such as kerosene may be used by parents. It's important to know what your local resistance patterns are when determining treatment. Table 37-6 talks about treatment options for pediculosis. Choosing the correct product is very important, but proper application is going to be key to success. prior to using a pediculicide, it's important not to use a shampoo that contains a conditioner or a cream rinse or petroleum products on the hair. Keep the product out of the eyes. Apply to damp hair. Make sure that the hair is damp and not wet, as wetness will dilute the product. It's important to follow the directions on the product, and most recommend applying at nighttime so that the hair can dry overnight. It's important not to rewash the hair for 1 to 2 days following the treatment, and if necessary, reapply in 7 to 10 days. Permethrin 1% is the treatment of choice for head lice for kids due to its safety and can be used with children older than 1 month. It has good efficacy and a 10-day residual. Other products are listed in the book, and you can read those. The second phase of taking care of lice is the removal of the nits. After removing the nits, and this is something that needs to be checked frequently, is then trying to clean the environment. It's important to launder sheets, towels, and clothing, any headgear, anything that's been close to the child's head. Anything that can't be washed should either be dry cleaned or stored in a plastic bag for up to 2 weeks. This includes stuffed animals, bedding, things along those lines. It's important to vacuum play areas and areas where the child sits, meaning sofas, recliners, the car, daily. It's important to soak brushes, combs, and any hair accessories in the pediculicide as well. Complications of the treatment could be secondary bacterial infections. Education is key with this condition, that you have to do daily and sometimes more than once a day to weekly checks for lice. Educate about how lice progresses, how it's not a social disease, and needs to avoid excessive or unnecessary treatment, and discourage a no-nit policy in school. There's many elementary schools, preschools that say if a nit is found on the hair, whether it's viable or not, that the child is not allowed in school. Other suggestions are for girls that have long hair to keep their hair braided and away from exposure to anybody else. Teach the kids not to share brushes, combs, hats, hair bows, things along those lines. And as we talked about earlier, I believe that the lice and the nits like clean, smooth hair. One way of avoiding that is to for girls and boys, is to put some product in their hair. So that could be some mousse, that could be hairspray, things along those lines that will not make the hair shaft as agreeable for it to come attached to. Next, let's talk about some scabies, which is caused by a mite called the Sarcopetes scabii. It burrows into the epidermis and can cause intense itching. It is highly contagious and happens, or you can catch it in close contact and from sharing clothing or linen. So the female mite likes to burrow under the skin and can lay up to 3 eggs a day, and these eggs hatch in 3 to 4 days, and they have a lifespan of about 15 days. So after someone has been infested with scabies, there's a sensitization where you can have intense itching. Scabies can occur in all socioeconomic groups and all age groups. However, it is rare in African Americans. On your clinical findings, you're going to find itching worse at nighttime and becomes progressively intense. The patient has fitful sleep, is cranky because they're up a good bit of the night being uncomfortable. On physical exam, you're going to see some S-shaped burrows. This can be found in the webs of the fingers, the sides of the hands, the folds of the wrist, and the armpits. You'll see vascular pustule lesions in infants and young children, and there may be secondary lesions. You may see itchy papules and red-brown nodules. Diagnostic studies include microscopic scrapings. This is not something you use KOH for, and you can do the burrow ink test to stain for the burrow. Differential diagnoses include a papular urticaria, dermatitis, and insect bites and folliculitis. Management includes pharmacological treatments with ascarbicide in a thin layer over the entire body. This includes the head and the face, head and the face, excluding the eyes. The area of importance is under the fingernails, the scalp, behind the ears, in all folds and creases, and the feet and the hands. You would reapply in 7 days on anyone that is symptomatic. Permethrin is the drug of choice for scabies, and it can be used with children as young as 2 months old, but with this product you would apply a thin layer to the entire body from the neck down and rinse off after 8 to 14 hours, and treatment may be repeated in 1 week. You can do simultaneous treatments of close contacts. It's important to wash the linens, clothing, and vacuum of the house like it was with lice, and store non-washables in a sealed plastic bag. Complications include secondary bacterial infections, and it's important to educate the patient and the family that the rash and the itching can persist up to 3 weeks. It's important also to avoid overbathing and offering any further irritation to the skin. The child should not be infectious 24 hours after treatment and may return to school or day. Let's talk a little bit about allergic and inflammatory reactions of the skin. First, we're going to talk about acne vulgaris. This is an inflammatory disorder where we have excessive sebum in the follicles. There's keratinous debris and bacteria can accumulate. Although rarely serious, we know that acne can cause permanent scarring and definitely decrease self-esteem. It is often a significant concern for the adolescent and can have a serious effect on social development. Acne also is the most common skin disorder and affects approximately 80 to 85% of individuals between 11 and 30 in the U.S. So there's 4 mechanisms that can lead to acne. We can have sebaceous follicles that are plugged with the keratin material. We have colonies of anaerobic bacteria that can grow. There can be sebum and androgen production that expands the follicles, and then there can be inflammation and pustules formed. On your clinical findings, it's important to ask if there's family history of acne, when pubertal development and menstrual history has started, facial or hair products that are used, oral or topical medications, any treatments that have been used for the acne and the results, if the child is participating in sports, has a job, what kind of job, and if there are other medical conditions. On physical exam, clinical findings will show non-inflammatory lesions. You may notice a follicular plug localized on the face or the trunk. There also may be open comedones, blackheads, which are papules, and they can have a blockage at the mouth of the follicle, and these can be seen at the face, the upper back, the shoulders, and the chest. And then there can be closed comedones, which are whiteheads, and these can be semi-soft, and these are precursors to inflammatory acne. And then there can also be inflammatory lesions, and these can be secondary to a rupture of a non-inflamed lesion. These can include papules, pustules, excoriation, lesions that crust, nodules, cysts, scars, and sinus tracts. And all of these are more likely to scar. Differential diagnoses includes cosmetic or drug-induced acne, rosacea, flat warts, or folliculitis. Management includes reducing the excessive sebum production to counteract the abnormal desquamization of the epithelial cells, to decrease the proliferation of the organism P. acnes, and prevent or decrease scarring. Choice of treatment depends on the extent, the severity, and the duration of the disease and what type of lesions you have. So on box 37-7, there's an area talking about commonly used medications for treating acne, and then on table 37-7, there is a table that talks about different treatments for acne. I encourage you to look at these, as these are likely going to be conditions that you will see in primary care. There's a lot of education that can go along with this condition, and it should be the first priority. The adolescent needs to be aware of realistic expectations and understand the process. There's lots that can be done for self-management, and this can include washing the face twice daily with a mild soap, only using non-blocking products. Products that are used on the face should be labeled as non-comedogenic. They should identify aggravating substances that they may use. And also be aware that there are certain aggravating factors such as stress, heat, humid weather, or jobs if they are working in a restaurant that could impact their face. Medications to treat acne vary by the action and the route of administration and the strength. You will find that there's topical and systemic preparations. Topical keratolytic and comedolytic agents minimize follicular obstruction. So there's topical retinoids such as triotin, adapalene, and tazarotene. There's also antibacterial keratolytics such as benzoyl peroxide and azelaic acid. Other topical antibodies control the inflammatory process, and these could be topical clindamycin, erythromycin, or Bactrim, and then topical erythromycin or clindamycin with benzoyl peroxide. Oral antibiotics that can decrease bacteria on the skin. It's important to use it for the shortest time period, include tetracycline, erythromycin, minocycline, and doxycycline. There are some specifics of each of these medicines in the book on how to take, what to take it with, and what not to take it with. I'm not going to go over those, so I encourage you to review those. Other medications include oral retinoids for severe non-reactive acne. It's contraindicated in pregnancy and requires an evaluation by a dermatologist and enrolling in the iPledge program, and it would require blood draws to make sure that the adolescent is not pregnant. Hormonal and other therapies for females is to oppose the effects of androgens on the sebaceous glands, and this is often achieved with oral contraception that provides both estrogen and progesterone, and there are several on the market that are FDA approved to treat acne. Complications include treatment failure, and this may be from a lack of motivation or education, and also the associated decreased self-esteem and poor body image. But it's important to educate the adolescent that acne will often get worse before it gets better, and that there are other products on the market if one line of therapy does not work. Okay, let's talk a little bit about contact dermatitis. It's an acute and chronic inflammation from a hypersensitive reaction to a substance. We can see a dry skin dermatitis from low humidity, excessive soap, nickel dermatitis, a lip liquor dermatitis, phytophotodermatitis related to sun exposure after contact with plants and juices, plant oleoneurasins from poison ivy, oak, and sumac. There can be juvenile plantar dermatitis, which mimics a tinea pedis, and there can be latex dermatitis. So for contact dermatitis, if we're talking about like having excessive saliva, urine, or feces can cause those skin areas to be impacted. Baby wipes, bubble baths, and adhesives can cause issues, and if urine or feces is kept on the skin for an extended period of time, you can have diaper dermatitis. There are certain allergens that can cause contact dermatitis. You can have a sensitization to an allergen with a subsequent type 4 delayed hypersensitivity response. And then we also know that certain products such as shoes, nickels, wool or rough clothing, topical medication, soaps, preservatives, or poison ivy can initiate a contact dermatitis response. On your clinical finding, it's important to take a good history, contact with any new or unusual substances, repeated exposure to any substances, has there been issues with diarrhea or infrequent changing of the diapers, rash localized to a specific area. Physical exam would include the area of involvement, the shape of the rash. The severity of the rash is going to depend on the length of the exposure. Document if there's issues with chafed, shiny skin, mild to severe redness, peeling, fissures, red patches, erythema, vesicles, weeping, hyperpigmentation, that lichenification that we talked about earlier, the leathery appearance in chronic conditions. Your differential diagnosis could include atopic dermatitis, impetigo, herpes, psoriasis, and seborrhea. Management is going to include Burrows solution to ease discomfort, emollients to restore moisture, topical corticosteroids. It's important if this is a lip-licking dermatitis not to use a flavored lip cream. Oral antihistamines may be helpful, and then to refer to a dermatologist or an allergist if there's worsening symptoms. Okay, diaper dermatitis. It's the most frequent contact dermatitis, and it's typically associated with improper hygiene or cleansing of the perineum. Chemical irritants can cause prolonged exposure can cause the irritation with urine, feces, or other products that might be put on the bottom. It can also be caused by mechanical irritation from the diapers. If you have a child that is not in disposable diapers and wearing cloth diapers and plastic plants, it can cause that occlusion of the skin, as where a disposable diaper wicks away the moisture. The cloth diaper is unable to do that, and it can cause aggravation of other skin conditions by wearing diapers as well. In our clinical history, you're going to try to get more information on the type of diapers used. Has there been any change in the product? The frequency of wet diapers, and if there's increase in liquid stools, the frequency of diaper changes, the methods of cleaning during diaper changes, any new baby care products, medications, or any recent use of antibiotics. On physical exam, you're going to look for any any chemical causes. Does the skin look shiny? Is it peeling? Is there a red rash? Any mechanical causes is going to include on the skin, you may note redness, macerated or dry skin. And then hygiene causes, any findings, poor general hygiene, if there's wet diapers or noted stool on the bottom, etc. Your differential diagnosis is going to include contact dermatitis, infection, atopic dermatitis, psoriasis, seborrhea, and scabies. Management of this condition, prevention is best. Doing frequent diaper change, applying a greasy lubricant if the skin is dry. A&D is a great product as it has some vitamins, and it will offer a barrier and then not allow the stool or the urine to have direct contact with the skin. And it's also important to use thick absorbent diapers. Management also includes exposing the bottom to air, a Burrows solution if the areas are weepy. Zinc oxide can decrease friction and moisture. Hydrocortisone cream can be helpful for redness. It's important to increase the baby's fluids to dilute the urine, and add a topical antifungal cream if there's no response. Complications may include a secondary infection and may need to be referred to a dermatologist if there's severe erosion, if there's any bulla, large papules, nodules, or purpura. Next, we're going to talk about seborrheic dermatitis, and this is a chronic inflammatory dermatitis seen as cradle cap in infants or dandruff in adolescents, and it's overproduction of the semen, and perhaps has some saprophytic yeast production. Seborrheic dermatitis is mostly seen in early infancy and adolescence, and is more common in the spring and the summer. Management of it includes antifungal agents, and these include your azoles or selenium sulfide. I'm going to back up. I think I skipped part of this slide. So we talked about the overproduction of sebum. Clinical findings, it's important to assess at what age were these symptoms noted. On physical exam, you may notice some flaky crust of yellow greasy scales on the scalp, face, or the diaper area, and mild flakes with dandruff, and it's not itchy. Differential diagnoses could be an atopic dermatitis or candida. We talked about the antifungals, anti-inflammatory agents such as a topical steroid or a calcineurin inhibitor. A keratolytic agent, such as a salicylic acid or urea, may be needed to remove excessive scales. In young children and infants, it's self-limiting. Applying mineral oil to the scalp before shampooing is very beneficial to help remove the scales. Also, you could use a soft brush or a toothbrush. If there's a facial dermatitis, a ketoconazole topical preparation can be used. For scalp dermatitis, some medicated shampoos or steroids can be used. Complications may include secondary infections. So let's talk briefly about some drug eruptions before we finish off this video. Drugs taken systemically can result in a variety of skin reactions, and there's two most common types of drug-related eruptions found in kids. One is called the morbilliform, and it is more measles-like rash. And then the other is a urticarial, which is seen by reddened wheals. These can be immunologic or non-immunologic. Most common drugs that can cause these eruptions include NSAIDs, penicillins, cephalosporins, sulfa antibiotics, anticonvulsants, and oral fluconazole or ketoconazole. It's important to ask your history about medications in the past 3 to 4 weeks, any degree of itching, and any possible systemic symptoms. On physical exam, you may notice symmetric macular rash that may become papular or confluent. It may begin on the trunk and extend to the extremities. Diagnostic studies are only ordered if necessary to rule out your differential diagnoses. These could include viral exanthium and toxic erythema. Management includes discontinuation of the drug, antihistamines if there's itching. Systemic steroids are usually not indicated, and if there are continued issues, then a referral would be necessary. Complications of drug eruptions may be an alteration in body heat and water loss. There may be progression may lead to a toxic epidermal necrolysis or Stevens-Johnson syndrome. It's important for education of the family that the condition may worsen before improving, the risk of further exposure to the medication, and to wear a medical alert bracelet or identification if it's a life-threatening allergy. Okay, we're going to wrap this one up, and hopefully there will be only one more. Thank you for your patience.